Well, it's just now noon, and we want to be cognizant of everyone's time today. We would like to welcome you to the Michigan Opioid Collaborative's webinar for December on buprenorphine initiations in the era of fentanyl. We want to just remind everyone to mute yourself unless you have a question or would like to interject. Please feel free to unmute yourself or put your question in the chat. We are so grateful for all of you to join us today, and we will go ahead and get started. So as you'll see, the activity code and the QR code are on your screen. It will expire on December 17th at noon. So if you can please take a shot of that, or feel free to click the link at the top, www.eeds.com. We would love for you to get your CEUs as needed. So we'll go ahead and get started. Before we do, I would like to give a little overview of the Michigan Opioid Collaborative and what we do and how we might be able to help better serve our communities around the state of Michigan. The Michigan Opioid Collaborative is a grant-funded program aimed to increase the availability of MOUD treatment in Michigan, as well as bring awareness and education to all SUDs. MOC offers free same-day consultation services to providers for any patients with SUD. MOC offers quarterly waiver trainings as well as webinars, such as this one, on a variety of educational topics on addiction, healthcare, and substance use topics. We provide support for diagnosis, treatment planning, and medication management. We have a hepatologist on our team who offers Hep C treatment consultation within 24 hours, and she also facilitates a biweekly case consultation webinar to review cases with providers. We have a 3-part webinar series and several HCV resources on our website. We are also now offering webinars on non-opioid SUDs, as well as discussion-based webinars on polysubstance when treating opioid use disorder. Our team has been working hard on some toolkits that are all available on our website that help providers have more resources when treating patients with SUD. You'll find at the bottom of the screen is our general email. Feel free to email us there if you have questions or concerns. Or after this webinar today, very shortly, your local behavioral health consultant will be reaching out to you, and feel free to discuss any questions, concerns, or joining MOC with them. So my name is Megan Long. I am a behavioral health consultant with the Michigan Opioid Collaborative, and I serve the Western region. I'm joined by a few of my coworkers here today, and we are happy to answer any questions or concerns that you may have throughout the webinar today. I would also like to go ahead and introduce our speaker today. Nathan Menke, MD, PhD, is a clinical assistant professor at the University of Michigan Medical School. He obtained his medical degree from the Ohio State University School of Medicine and his PhD in biochemistry and molecular biology from Virginia Commonwealth University. He completed an emergency medicine residency at the Medical College of Virginia, followed by a fellowship in medical toxicology at the University of Pittsburgh Medical Center. He is board certified in addiction medicine, emergency medicine, and medical toxicology. Dr. Menke joined the Department of Psychiatry at the University of Michigan in 2021 and is the current medical director of the Addiction Consult team. So we would like to welcome him and all of you for joining us on our webinar. I will stop my share and turn it over to you, Dr. Menke.
So thanks for having me. I think this is a topic that we're all interested in because we're all struggling with it. Every year I've been practicing, we've been having worse and worse times with the opioids. The patients are getting harder and harder to treat, and we're having less and less success. And so what we're going to talk about is why it's so challenging to do buprenorphine initiations on patients using fentanyl, compare and contrast the different formulations of buprenorphine and how that can affect their roles in initiations, and then how we can implement micro and macro dosing strategies for initiations. And so I'm sure you're all aware of the 3 waves of the opioid overdose epidemic. So the first wave was the prescription opioids, the Sackler family, the OxyContin. And then once there were deterrent formulations, then heroin became a lot more popular as it was harder to get and it was harder to use the prescribed medications. And then the most recent one is the fentanyl wave. And we'll talk about why fentanyl has become so popular. And then some people say there's a fourth wave where we have a combination of synthetic opioids plus a sympathomimetic, so a lot more meth and cocaine. And these deaths continue to rise. I think 2021, it was still over 100,000 deaths. And the reason fentanyl is so deadly is if you look at the amount that it takes to overdose on, so heroin versus fentanyl versus carfentanil. If you look at this amount, I mean, this is the amount of carfentanil it would take to unintentionally overdose. So it's a very, very small amounts. And when you're talking about your street pharmacist or drug dealer putting these medications together, you can imagine that it's not the most precise methodology and that you're going to get a lot of variations in doses. And so what is fentanyl? It's a synthetic opioid, first synthesized in the 60s. It's about 100 times more potent than morphine, and it's currently the most common drug involved in overdose deaths. It's really nice from a medical perspective because it has a rapid onset, it has very predictable metabolism and inactive metabolites. So in the hospital, when we have patients that need opioids for procedures or traumas, fentanyl is a great medication. It's very, very easy to use and relatively safe. Another important thing about fentanyl is that it does not trip the opiate urine drug screens, right? So these urine drug screens are designed to detect morphine. You know, opiates are morphine and codeine. They're the natural, I guess you would say natural opiates that occur in the poppy plant. And so fentanyl is purely synthetic and it does not have a structure anything close to morphine. And so if you're using immunoassays, which the urine drug screens are, you're not going to detect it. So you need a specific fentanyl assay, or you need something like a GCMS or a time of flight in order to detect it. And the other important thing about fentanyl is its half-life. It's got a very short half-life, terminal elimination half-life at 219 minutes. So it is shorter acting than the majority of the opioids we use. It's shorter acting than oxycodone, than morphine, than heroin, than Dilaudid. And that's why it makes it so interesting that we're having such problems with it. And when you talk about fentanyl, you're not just talking about fentanyl, you're talking about all the fentanyl analogs, right? So you have, you know, acetylfentanyl, fluorofentanyl, furanofentanyl, carfentanil. They're just fentanyls with different side chains or different substitutions. And we have very little pharmacokinetic data for these fentanyls on humans because they're not designed for human use. So they're a lot less predictable than pure fentanyl because we have a ton of studies using fentanyl for medicinal uses. So we are very familiar with it as a drug, as opposed to these other ones where, you know, they're just not designed for human use. And so why did fentanyl become so popular? And the reason is it's just super cheap, right? So the precursor that 25 grams cost about $87. And this is from an article in the Wall Street Journal from, I can't remember when it was like 2019, maybe around that time. You combine it with other chemicals, about $720 to produce fentanyl. So you get 25 grams of fentanyl for about $810. And then you can sell that for $800,000, right? You don't need to grow any plants, right? All you need is a lab, right? And then these common chemical precursors that they're not controlled, right? Because they're just chemicals. And so when you're talking about the synthesis of fentanyl, it's super easy. This is just pure organic chemistry that you don't need advanced degrees to do, and you easily get fentanyl. And this is why it's so hard to regulate. Like, how do you prevent people from synthesizing this substance? It's virtually impossible. And so this is why it's so cheap, it's so prevalent, and it's so difficult to stop, because and these are just like two simple pathways. There's like 6 or 7 other ways of synthesizing fentanyl. And that's not very important, except for the fact that you might see some of these compounds in your drug screening. So acetylfentanyl often comes up. You often see the precursor, the 4-AMPP, desprolyl fentanyl is another name for it. And we see these all the time in our drug screens. And so, again, this is just so simple. Now, when you're talking about fentanyl, we're not talking about medicinal fentanyl, right? So what are our patients using, right? And how potent is it? And it's a very important issue, because this is one of the reasons patients overdose all the time, is that the quality of their substance they're using is going to change. It's going to change depending on where you are, what your shipment is, who your dealer is, all that stuff. And so when we're talking about purity in the context of non-prescribed opioid use, it's the amount or quantity of a specific drug in a material product, right? So it can be reported as percent or weight. And then potency is defined by the strength of effects of the drug product can have in humans. And so the reason that's important is because when you buy fentanyl, you buy a gram of fentanyl on the street, it's not a gram of fentanyl, it's some amount of fentanyl plus some amount of other stuff, right? And that's why we talk about potency of what you're purchasing, right? We know the potency of fentanyl, but we don't necessarily know the potency of what you're purchasing, because if you buy a gram of fentanyl and it's 50% fentanyl, that's a lot more fentanyl than if it's 20%, right? The potency of that product you purchase is different depending on how much fentanyl is in it. And so that's why we talk about things like potency index. It's the combined effects of all the opioids. And so we do this, again, based on fentanyl, because that's what we're most concerned about. So it's relative pharmacological activity that's normalized to 10% fentanyl, normalized to a unit of 1, right? So these are just kind of ways you can compare the strength of the product you see on the street. And the best way to understand this is just to do a couple examples. So if you have a sample of 100 milligram powder, 1% is fentanyl or 1 milligram, right? You can do it either one. 50% heroin, 49% mannitol, right? So it can be mannitol, it can be some other substance, non-active. We see a lot of Benadryl in our fentanyl. So in this case, the potency index is 0.2, right? It's mostly heroin, and heroin's about 50 times less potent than fentanyl. So despite the fact that half of it is an opioid, it's not fentanyl. So it's a lot weaker than 10% fentanyl, right? If it was 10% fentanyl, the PI would be 1. So in sample 2, you have 20 milligrams of fentanyl, 10% heroin, and 70% mannitol. So in that case, the potency index is 2, right? So it's twice as strong as fentanyl, and the heroin doesn't even contribute to the strength of it, because there's only 10 milligrams compared to 20 milligrams of fentanyl. And again, it's 50 times less potent, so it basically has no effect. And then lastly, you have something, if you have something like carfentanil, right? So carfentanil is about 100 times more potent than fentanyl. So if you had a product that was 10% carfentanil, 90% mannitol, that's got a PI of 100, right? So that's 100 times more potent than 10% fentanyl. And again, so you can see why it's so easy to overdose. You have no idea what you're purchasing, and you have no idea what the potency index is. And, you know, they sell fentanyl test strips, but that's pretty much useless to our patients, because every sample they get has fentanyl in it. So if they're doing opioids that they're purchasing, it's almost always fentanyl, even when they're buying pills, because the majority of the pills they're purchasing are pressed fentanyl, right? It's very difficult to get oxycodone or hydrocodone or whatever when you purchase it, unless you're buying it from somebody who has a prescription that you know, because if you're just buying off the street, you're probably getting fentanyl. And so how much does that equate when we're actually talking about real samples that were analyzed? And so this data is from Philadelphia, and this is going to be very regional, right? It's going to depend where you are, but it's a good rough estimate to understand how much opioids our patients are using. So, and then how do patients tell you the amount they use? So when I worked in Pittsburgh, they told us in bags, right? They would say, I use a bundle a day, right? 10, which is 10 bags. Or sometimes they would do it in grams, but rarely. And sometimes they would do it in dollar amount. typically in Detroit, we hear grams or dollar amounts. So a bag is about 0.1 grams, which is about $10, which is about 90 oral morphine equivalents. And so an oral morphine equivalent is if you converted the fentanyl to morphine, you would have to give 90 milligrams of oral morphine to equate to the dose of fentanyl. And so if they're using 10 bags a day or 1 gram, that's 900 milligrams. We oftentimes see patients using 2 grams, and that's 1,800 oral morphine equivalents. And if you're talking about a treatment dose for a patient, so imagine a patient with a broken arm, you're putting them on like 5 milligrams of oxycodone every 4 hours. So 5 times 6 is 30. It's a 1.5 equivalents to oral morphine equivalents. So you're talking like 45 OMEs. That will be a therapeutic dose for an opioid naive patient. And our patients are getting 1,800 a day. And this is one of the reasons we're having such trouble with the fentanyl. If you want to think about comparing it to methadone, about 40 milligrams of methadone is around 120 to 160 OMEs. You know, the exact amount isn't that important. It's, you know, debatable about the exact conversion, but again, it's just these general numbers. And so the classic teaching when I was a resident was 40 milligrams of methadone will treat pretty much all withdrawal. And that's really not true anymore. If you give somebody 40 milligrams of methadone who's using 2 grams of fentanyl a day, it's probably not going to be enough. And so oftentimes these patients need a minimum of 400 oral morphine equivalents to prevent withdrawal. And again, this is I'm talking about severe opioid use disorder. Typically, these patients are injecting or insufflating 4, 5, 6 times a day. This isn't the patient that's using oxycodone that they're purchasing from a friend. This is the severe OUD patients. And so another important characteristic of opioids are their lipophilicity, right? So this is how much they like lipids, basically, I guess is the best way to put it. And if you look at fentanyl, it's very lipophilic. The octanol water partition coefficient is just how much of the fentanyl would go into the octanol versus water. So it's just how lipophilic is. So bigger numbers mean more lipophilic. And so it's very lipophilic, very lipophilic. And this explains why we have such trouble with fentanyl. Despite having a super short half-life, it is very lipophilic. So what ends up happening is you get a depot effect, right? So these patients who chronically use every day, inject 4 or 5 times a day, it gets into their tissues, and then it slowly releases over time. And so there was a case series done where they checked patients' urine levels of fentanyl and norfentanyl in a inpatient substance use treatment facility where they would not have access to fentanyl. And as you can see, the fentanyl stays positive for quite a few days, which is not what you would expect based on the pharmacokinetic studies of fentanyl, which were done using 1 dose. Right, you inject a patient with 1 dose of fentanyl, terminal half-life's 219 minutes, but it is absolutely not 219 minutes in patients who are chronically using. And so for this small subset of patients, the average time for fentanyl clearance was 7 days, 13 days for norfentanyl. And there was one patient that was positive for fentanyl for 19 days who never cleared their norfentanyl. They were discharged after 26 days with positive norfentanyl in their urine. And so this is considerably longer than you would anticipate from other short-acting opioids, right? If you take oxycodone in 4 days, it's going to be pretty much gone from your urine, right? So this is why we have such difficulty. So fentanyl basically turns into methadone, only worse, because it's super lipophilic. So when you inject it, you get that really fast euphoria. So these patients are getting euphoria like heroin, or even worse than heroin, plus they're getting the long-acting effects like methadone. And this is why patients are suffering from precipitated withdrawal. You know, they're reading online that if you wait 24 hours and start buprenorphine, you'll be fine, which is absolutely not true anymore, right? When people were using heroin, that was 100% correct. You just wait 24 hours, you're not going to precipitate withdrawal in heroin. It's just not going to happen. But it absolutely does in fentanyl. We've had patients who don't even start withdrawing until hospital day 5, right? Patients that we know are not using in the hospital who are surprising our team. I remember we saw a patient who was complaining of withdrawal on hospital day 5, and our nurse was like, withdrawing from what? What could you be withdrawing from on day 5? And it was fentanyl. Is because it just took so long for him to metabolize and to clear his body stores to reach a point where he was having significant withdrawal. And so the next part of this is the interaction of fentanyl and buprenorphine. And I apologize, a lot of this stuff is pretty dry. It's pharmacology. I love this stuff because I'm medical toxicology, but most people don't. And so buprenorphine is a partial agonist at the opioid mu receptor. It has high affinity, slow dissociation. We'll talk about that more in a little bit. It also antagonizes opioid kappa and delta receptors. It has poor GI bioavailability, but good sublingual bioavailability. That's right. And so this is why we tell patients, don't chew it, don't swallow it, because you will not absorb it. It has to go under your tongue or into your buccal membrane if it's a buccal formulation. And so this is just a picture demonstrating the effects of buprenorphine. So it's a potent analgesic because of its mu opioid receptor binding. It's partial agonist, so you have a ceiling effect on respiratory depression and euphoria, and it has much less side effects than full opioid agonists. And this is what we counsel patients when we recommend converting from a full opioid agonist for pain to buprenorphine, much less adverse effects. It also antagonizes the delta and the kappa opioid receptor, which actually helps patients' mood. Some psychiatrists use it for treatment-resistant depression. And then lastly, it is a opioid receptor-like agonist, and that's thought to cause some more analgesic effect. So peak plasma concentrations after the first dose of transmucosal is about 40 minutes to 3.5 hours after dosing. It's got a very long acting half-life, 24 to 69 hours. In theory, you can do less than daily dosing. Typically, our patients do better with multiple times a day dosing rather than doing it every other day, which you could, in theory, do based on the kinetics of the medication. And so there's a bunch of different formulations, and I'm not going to go over all these. You know, there's sublingual films, there's sublingual tablets of the combined buprenorphine and naloxone formulations. There's the buprenorphine only, buccal film, sublingual tablet, transdermal patch, injection, and there's immediate extended release injection that goes, once a month versus the immediate release injection where you give IV. And so these are all the different formulations you can potentially use for this treatment. And so when we talk about binding affinity, what we mean by that is how well does it basically stick to the receptor, I guess is the easiest way to think about it. And the lower these numbers, it means the higher the binding affinity. So tramadol has the lowest binding affinity, and this is one of the reasons it's one of the weakest agonists we have. Fentanyl is about 1.3, whereas buprenorphine is 0.2, right? So that's really, really small. And what that means is it's going to displace any full opioid agonist that's on the receptor, assuming it's not sufentanil, and will potentially block the effects of any full opioid agonist, right? So that's both a feature and a bug, right? So if you're talking about precipitated withdrawal, you're talking about displacement of that fentanyl or heroin or oxycodone or whatever other full opioid agonist from the receptor, which causes immediate withdrawal, right? And so what we typically, again, these are classic teachings, 24 hours from last use of short-acting mu agonist, at maximum. You could usually do it even shorter than that. 72 hours from the use of long-acting mu agonist. And this is precipitated withdrawal is not due to the naloxone that's in Suboxone, right? This is a very common misconception that patients have, as well as healthcare providers, right? It's not the naloxone, right? If you look at the binding affinity of naloxone is less than buprenorphine. So buprenorphine is going to preferentially bind to these receptors over naloxone. And the concentration of the buprenorphine drug is higher, significantly higher in Suboxone. So you have higher binding affinity, higher concentration, very unlikely to be precipitated withdrawal is very unlikely to be significantly affected by the dose of naloxone, right? The naloxone was added to buprenorphine to try and deter injection. And so precipitated withdrawal is a disaster. And one of the reasons it's a disaster is it makes patients very, very, very hesitant to ever try this medication again. They will absolutely refuse because it was the worst experience of their life, was to go into precipitated withdrawal by buprenorphine. And so it's a huge barrier to treatment. So one of our goals is to never precipitate patients. And so that makes us much more conservative than a lot of the textbooks, because we don't want to take any chances. So if you read the textbooks, a lot of times they'll say 8 hours from last use of short-acting mu agonist, but I typically won't do it less than 12 under any circumstances. And oftentimes I like to wait 24 if I can. And so what happens if you do precipitate withdrawal? Right. So you treat it as any other withdrawal, right? We'll talk about the comfort meds in a little bit, but our additional treatment is more buprenorphine. And so when you start an initiation for a patient, you should tell them that if they do suffer from precipitated withdrawal, the treatment is more buprenorphine. And that's a really, really hard thing for patients to understand and to agree with. So you just made them sick, the sickest they've ever been in their life with buprenorphine, and you're telling them you want them to take more. So you better have that conversation before it happens, because if you try and have that conversation while they're puking, it's not going to work, and they're just going to leave and likely go use, because it's the only treatment for their withdrawal, right? And so this is kind of the figure that demonstrates why we get precipitated withdrawal, even though buprenorphine is an agonist, right? But there is a difference in the activation of the receptor from buprenorphine as compared to a full agonist, regardless of what the full agonist is. And it's that difference that causes the precipitated withdrawal. And so the comfort medications we typically recommend for these patients, oftentimes we'll put patients on a clonidine patch, depending on their hemodynamics, 0.1 or 0.2 milligram patch. And then we can even add supplemental clonidine to that, assuming their blood pressure and heart rate are able to tolerate it. You want to treat their symptoms. So you treat diarrhea, you treat nausea, vomiting with Compazine or Zofran. During this process, I recommend scheduling NSAIDs and acetaminophen, assuming they're not medically contraindicated. Just put them on these medications. That helps prevent the muscle aches and the bone aches they can have. You want to help patients sleep. So trazodone at night, 50 milligrams, you can even go up to 100 milligrams, and then you can do hydroxyzine for anxiety, and it helps sedate patients. So it's very important that you have a treatment regimen. And again, this is just one. There's a million different formulations of medications for treatment of acute opioid withdrawal. Just pick one you feel comfortable with, and that you can counsel your patients on how to take. And so if you do precipitate withdrawal, I always try and give patients clonidine tablets, assuming they can take PO at that point. You give them, and again, it's going to depend on whether, if they're in the hospital and they have an IV, it's a lot easier than if they're an outpatient and you're trying to give them PO on top of their vomiting. And so there's, I guess, three main buprenorphine initiation strategies at this point. So the traditional initiation, the SAMHSA recommendations, stop full opioid agonists, the patients are abstinent, wait for the cows to be mild or moderate, and then begin buprenorphine. And they recommend 2 milligrams sublingual, repeat cows in an hour, and keep going to a max of 8 milligrams. And I've never done my buprenorphine inductions like this. The only time I would consider doing that using 2 milligrams is if they were opioid naive patient. What I would do for any patient taking a significant amount of opioids is I do 8 milligrams, and typically 8 milligrams sublingual BID. If you're not sure how much they're taking, you tell them to take 8 milligrams. If they're not sedated, take another 8 in 12 hours, or you can do something along those lines where they can cut the films. But I would not initiate less than 8 milligrams unless they're opioid naive. If they're a patient who has been institutionalized, whether it's SUD treatment, the hospital, prison, haven't used in a month, and now they're having urges and cravings to use, or they unintentionally overdosed because they had no tolerance and they went and used a normal amount. At those patients, I would do the 2 milligrams and then titrate to sedation. Again, the data demonstrates that most patients get the most benefit from 60 milligrams daily. And so that's usually my goal dose for these patients, minimum. If they're injecting fentanyl, I typically do 32 milligrams on the first few days and then drop it to 24 milligrams for at least 2 weeks. And I wouldn't even consider dropping it before then, just because we're having so many treatment failures with buprenorphine in this era of fentanyl. And so another very important dosing strategy that is almost mandatory in the days of fentanyl is microdosing. And so some people argue that you shouldn't call it microdosing, it should be called low dose based on the pharmacological definition of microdosing. But I mean, in my mind, you're giving a subtherapeutic dose in microgram doses. So microdosing seems like a pretty good name for it. And that's what most of the literature says. So that's pretty much what I stick with. But again, if you hear low dose buprenorphine initiation, that's pretty much what they're talking about. And so this is subtherapeutic microgram doses of buprenorphine with scheduled incremental increases over days. And this is designed to prevent precipitated withdrawal, because it's not the dose of the buprenorphine that causes the precipitated withdrawal. It's the rate at which the buprenorphine displaces the full opioid agonist from the receptors. So if you do that at a rate which is so slow that the full opioid agonist is barely displaced over time, you're not going to get precipitated withdrawal. And in fact, you can continue full opioid agonist while you're doing this very low dosing, because again, displacement is not high enough to cause precipitated withdrawal. And you can do that using buccal films, transdermal patches, sublingual films, which is classically the Bernese method from the city in Switzerland, where the first case report was published. And then you can use IV buprenorphine. At my previous hospital, we didn't have IV buprenorphine, and in my current one, we don't have it except in the OR. So I am not familiar with using IV buprenorphine for microinduction, so I won't be speaking about that. And then the newest treatment strategy is the macrodosing. And so the thought on that is, if you give high enough doses of buprenorphine, even though it's a partial agonist, you will get enough opioid receptor activity to prevent withdrawal. And so that means you have to do really high doses on the initial dose, greater than 12 milligrams. And typically it's a maximum of 32 milligrams daily, because that's not likely to help you. And if you're looking for the literature behind these dosing strategies, all you're going to find is case reports and case series. There's no randomized controlled trials on how these work. But a lot of people have been using these and having a lot of success with this. And I have heard people using pure macrodosing in the ER and not having patients suffer from precipitated withdrawal, but that has not been my experience. We've had a couple patients where they came into the ER and they'd already started buprenorphine too early and caused precipitated withdrawal. So we go immediately into the macrodosing to try and get them feeling better. And even after 32 milligrams in the first day, they still feel terrible. So we have not had the success that other people have described using macrodosing. And so what we typically do is a combination of the two. I like doing a microdosing initially, followed by a macrodosing after the initiation of the microdosing. And this also allows the fentanyl to get washed off the receptor, right? You remember the figure that the fentanyl levels are dropping. So you want to let them wash fentanyl out of their tissues before starting the high dose buprenorphine, in my opinion. And so how do you do the sublingual microdosing? And there's a million different ways you can do this. This is kind of the one we typically use, or some variation of it, right? So it's on day one, you give 0.5 milligrams. So that's a quarter of a 2 milligram film, right? And I have not seen any patient withdraw from that dose. So that dose is likely not high enough to displace enough full opioid agonists to cause withdrawal. So the the corollary to that is it is not going to provide any therapeutic benefit to these patients. They're not going to feel it. They're not going to know they got it. It's not going to help them at all. And so the classic, again, is 0.5 milligrams a day, increase it to 0.5 milligrams twice a day. Then you can do 0.5 4 times a day. And again, you can see this protocol for yourself. And this gets you to 16 milligrams on day 8. You can slow the protocol down, right? You can increase it by 0.5 milligrams a day. And that way, you won't precipitate them because that dose is too low to precipitate someone. So it's 0.5, 1, 1.5, 2, 2.5, 3. And then you can start increasing it to 4 milligrams, and then the 6 milligrams, and then 8, and then 16. And again, if you look at day 10 or day 8, I do the microdosing once I go to the higher doses. So I go 16 milligrams once, followed by the 16 milligrams in an hour. So a total of possible 32 milligrams on that day. You can also do a more rapid induction where you do 0.5 milligrams every 6 hours. And so again, this goes back to the pharmacokinetics we talked about, that you see the peak effect of the sublingual buprenorphine in guaranteed less than 4 hours. So at 6 hours, you should have already seen the peak effect. So you shouldn't cause precipitated withdrawal if you dose it 6 hours apart. Right. So if you do 0.5 milligrams every 6 hours, that gets you 2 milligrams in the first day. And then you increase it by 0.5 milligrams. So a total of 1 milligram every 6 hours. And that gets you to 4 milligrams a day. Then you can do 1.5. Or even if you want to be brave, you could do 2 milligrams every 6 hours and get up to 8 and skip a whole day and then go to the 16. And again, you need to try and stop all opioids prior to the high doses. And we'll talk about specific examples on how to do this. And so these cases are based on patients we have seen. This is a patient, a 20-year-old man with a history of severe opioid use disorder, who presented the ED via a FQHC referral for management of OUD. They weren't able to see him for, I think it was like 10 days. And so they sent him to the ER to get started. He's been having issues with opioids since he was 18. He's been able to maintain abstinence for a year and a half at a time. He did well on Suboxone in the past, but was removed from the program due to concurrent cannabis use. He tried methadone, not interested in methadone at this time. And then 10 days ago, he had pneumonia and felt terrible, and that triggered him to use again. So he's been using 0.25 grams, a quarter of a gram of heroin intranasally per day. His last use was just prior to walking into the ER. He's not been injecting during this relapse, but has a history of injection. And so for him, he took a day off work to come to the ER, but he couldn't go inpatient because he had a job. He did not want to, or he couldn't, take a break from his life to go inpatient to get off the fentanyl. And so he asked for a solution. And again, he used fentanyl right before coming into the ER. And so what we did was we offered him a microdosing protocol. And our service is inpatient only, but we do have the ability to do some limited telehealth visits. And so this gentleman, we started on this protocol, the 0.5 once, 0.5 twice a day, and then 1, then 2, then 3, then 4 twice a day, and then 16 milligrams daily. And so on day 5, he said it was going well, hadn't had any significant withdrawal symptoms. He didn't make any effort to contact us via phone. He had a little muscle aching, but nothing uncomfortable. He's been using small amounts of fentanyl several times this week. His goal was to not use any more fentanyl and then switch to the just pure Suboxone in the next couple of days. And then our follow-up call on day 8, he had no signs and symptoms of withdrawal when he took the 16 milligrams, and he felt great. And so this was a huge success that we got this patient onto buprenorphine without him having to miss work or unintentionally overdosing. So this was a big success for our service. Another case, and this is part of the reason we're having this talk, is a 32-year-old gentleman with a history of severe OUD, including intravenous use. He presented for bacteremia. So he went to Henry Ford because he had a wound that wasn't healing and looked infected. He had blood cultures drawn that were positive. He had left prior to the finishing of his diagnostic workup and was called back due to blood culture results. So he came to our hospital. He's been injecting for 6 to 7 years. His goal is to quit. He wants to abstain from all non-prescribed psychoactive substances, but he's petrified to resume Suboxone. When I say mildly hesitant, he's very, very hesitant. Because he had severe precipitated withdrawal when he tried it in 2019. He had profuse diarrhea, projectile vomiting, abdominal pain. And so this is the outcome we're trying to avoid, because again, it's been 2 years, 3 years, and he hasn't tried Suboxone again because of this bad experience he had. And he says he last used last evening. And so what we did was he was admitted to the hospital for these positive blood cultures. So we started him on the Butrans patch. And the beauty of the patch is that the kinetics are such that it is so slowly absorbed that you cannot cause precipitated withdrawal. It's impossible from the patch. And so, but the problem again, though, is it's not going to treat his withdrawal. It's not going to treat his pain. It's not going to treat his urges or cravings to use. So in these patients, we have to do a cross taper. So we have to add a full opioid agonist on top of this. Otherwise, the patient is either going to have an urge or craving to use or withdraw or have worsening pain and leave the hospital against medical advice and not receive the medical care that they need. So what we typically do is offer the patients PO oxycodone, 15 milligrams PO every 3 hours as needed for pain withdrawal. Our hospital does not allow a cow score on the floor, so we can only write it for pain or withdrawal. We can't titrate it to a cow score. And then we increase it up to 30 milligrams. And so if you give 30 milligrams 8 times a day, that's 240 milligrams. So that's 360 OMEs, right? So that may or may not be enough, because according to that information from Philadelphia, you're going to need at least 400 milligrams or 400 oral morphine equivalents to treat withdrawal. And so we have found this more and more, that the PO oxycodone is not working. And we'll talk about a case later where it didn't. So what we do is we leave this patch on for about 72 hours. And that lets you get to a blood level of probably around 2 milligrams of Suboxone sublingual, approximate equivalent. I mean, this is 2, maybe 3, something along those lines. And so what we do is we hold it at 9 p.m. the night before the initiation, and then we wait 12 hours, right? So we've let the fentanyl wash out for about 72 hours, right? So their blood fentanyl levels are dropping over this period of time. We're giving them oxycodone to prevent the acute withdrawal or minimize it as much as possible. And then we hold it. And it's important while you hold it that you're giving them medications to help them sleep and to help with any symptoms of withdrawal. So what we typically do is we schedule NSAID and Tylenol during this whole process, right? We don't make that PRN. We just schedule it. Just give them a gram of Tylenol 4 times a day. Give them your NSAID of choice scheduled. We typically like NSAIDs that dose twice a day, just for ease of use, so naproxen or Celebrex or something along those lines. We give them, again, something to help them sleep at night. Oftentimes it's trazodone. It could be whatever you choose. And then any medications they need for symptomatic treatment. And the other thing we like to do, again, for these patients, is put a clonidine patch on them when we put the Butrans patch on as well. Again, if their hemodynamics are able to tolerate it, this gives us a background clonidine level that doesn't require a PRN, right? The big issue in the hospitals is you write a PRN medicine, they may or may not get it, depending on the nurse. But if you put a patch on, you know they're guaranteed to get it. And so in the morning, he said it was the best withdrawal he's ever had and that he felt great. But unfortunately, he ended up leaving AMA. I can't remember if it was that day or the next day, because it did not suppress his urges or cravings to use, right? We have had this happen multiple times with these fentanyl patients, that even if we get to 32, we got him 32 milligrams on day 1, and it still wasn't enough to suppress the urges or cravings to use. He ended up leaving AMA and then died of an overdose about a month later. So we ended up doing the right things, getting him on buprenorphine, but we still weren't able to save his life. And this is another case that demonstrates how terrible this disease is. So we see the women who get admitted for buprenorphine or methadone initiations on OB, because we don't see that many in Ann Arbor, so our MFM aren't that comfortable with it. So we had a 28-year-old pregnant female who at 32 weeks who presented for detoxification from her fentanyl use. So she had a severe opioid use disorder. She was injecting fentanyl 4 or 5 times a day. She used a gram the day prior to admission. After she got admitted, she literally walked out before having anything done, and then went and used another 0.5 gram and then came back. So we started the B-Trans patch. They are able to do the CAL score on labor and delivery. And so what we did was we gave her oxycodone. We titrated her up to 30 milligrams every 3 hours, but it wasn't enough. This was not enough for this patient, so she ended up leaving. We had offered her a PCA, but she had tried one during a previous admission at another hospital, and it didn't work for her. So she preferred the PO oxycodone. And we like to give our patients as much choice as we can, right? Their lives are oftentimes terrible with very poor choices, and they've been mistreated oftentimes by medical professionals. So we, in part of gaining rapport with our patients, we give them the choice of how they want to be treated, that we want to treat them, that we want to make them feel comfortable, and we'll do the best we can. But because of the fentanyl, we will oftentimes struggle. So this patient left for 36 hours and injected fentanyl that whole time, and then comes back. So again, we started the patch, the B-Trans patch. We started on a clonidine patch, and she did agree this time to a hydromorphone PCA. And so we put her on 0.2 milligram demand, 6-minute lockout, 2.2 hourly max with a 0.2 milligram per hour continuous rate. But that wasn't enough, right? She was still withdrawing objective signs of withdrawal, not saying I feel bad, objectively diaphoresis, tachycardia, right? What you do not want in a pregnant woman. And so we titrate her up to 0.4 milligram demand, 6-minute lockout, 4.4 hourly max. And she ended up getting, I think, oral morphine equivalent of 1,400 milligrams in 24 hours to adequately suppress her withdrawal symptoms. So the PCA was continued for 4 days. It was discontinued at 11 a.m. The patient was given extra clonidine, Atarax, and then 4 hours later, we started buprenorphine 16 milligrams sublingual and repeat dose at 16 milligrams because she was having withdrawal symptoms after the first 16 milligrams. After the second 16 milligrams, she didn't feel normal, but she felt significantly better. And this patient went on to deliver at 39 weeks and is still doing great now. So this was, again, another success. But again, this is just so challenging to our service that the amount we're having to use to get these patients' withdrawal under control is exceptionally difficult. Another case, and this, we used a buccal formulation. This is a 42-year-old woman who had a fall that resulted in paraplegia with seriously life-limiting chronic neuropathic pain. She was having terrible pain in her bilateral thighs, and it was, burning. She'd tried every adjunctive medication without significant improvement. And somehow she ended up methadone 50 milligrams POBID by her PCP. And she ended up being admitted for cystitis. And she went on to tell us that she'd been insufflating and occasionally injecting a 1/4 gram of fentanyl every day for about 5 weeks. She had trouble injecting. She had no experience with it, and that's why she insufflated most of the time, because she just didn't know how to find a vein. And so her PCP told her they were no longer willing to prescribe her methadone because she was using and injecting and insufflating fentanyl. And so this patient was not someone who could get to methadone clinic because of her clinical condition. And so she wanted to do buprenorphine for the management of her chronic neuropathic pain in the context of opioid use disorder. And so again, methadone and fentanyl, we pretty much treat the same these days. Like, if we're going to do a conversion for a patient or initiation for a patient, if it's methadone or fentanyl, it doesn't really make that much of a difference to us. And so this is the treatment regimen we came up for her. And so we started her out at a buckle of 300 micrograms every 6 hours for 4 doses. And then we go up to 450 and then 600, then 900, and then 2 milligrams sublingual every 6 hours to 4 milligrams sublingual, and then 16 milligrams, followed by 8 milligrams every 8 hours. And again, we do this cross taper. So we leave her on the methadone for 3 days, slowly decreasing. We go 50 milligrams POBID, so her normal dose on day 1. On day 2, we just drop it by 10 milligrams, probably not enough for her to notice. And then day 3, we cut it in half, right? As the buprenorphine is going up, the methadone is going to come down. But if you do it that way, you're likely going to suffer from withdrawal, because that dose of buccal buprenorphine at 600 micrograms is probably not going to be enough to treat withdrawal from 100 milligrams of methadone or 50 milligrams of methadone. And so at that point, we add oxycodone, 20 milligrams PO every 4 hours, to begin 12 hours after her last dose of the methadone. And again, we do the 9 p.m. and then abstain from that, increase it to 4 milligrams. And this patient didn't, the worst she suffered was hot and cold feeling. That was the worst of her withdrawal during this process. And so that was a successful microdose initiation in these patients. And so there's reasons not to use microdosing as well. So if a patient's already having significant withdrawal and it's been, if I admit these patients to the hospital, I still always do microdosing, just because patients are still having precipitated withdrawal 72 hours after the last dose of fentanyl, even though their COWS is 11 or 12 or 13. But if a patient really wants to try it, we're willing to do it. We just counsel them extensively that we've seen patients have precipitated withdrawal at this point in withdrawing from fentanyl. And some patients just don't want to do it or don't think they can do this prolonged microdosing, which is actually one of the weaknesses, right? So you have a patient with severe OUD who has a moment where they absolutely want to quit. That's the only thing they want to do. And so putting them through a week-long process to make that happen is sometimes problematic. Oftentimes patients can't do the whole week, right? They just start using again on day 3, and the buprenorphine is not high enough to have any significant effects on them. And so the longer the microdosing, the less likely you are to precipitate them, but the more likely they are to quit the microdosing protocol. In the hospital, for us, it's easy because we have them under control. We can give them full opioid agonist. It's not a problem for us, but for an outpatient, it makes it much, much harder. Some patients just aren't going to be able to cut the strips. They're not going to be able to follow these complicated protocols, and they're going to cause themselves precipitated withdrawal. And then if they can't self-administer doses, or they can't dose sufficiently frequently, or and oftentimes in SARS, they will not cut strips like that. They just won't do that. So that would not be a reasonable plan for them. And so whatever plan you come up with, it's going to be specific to your patient and your practice, right? It has to be safe. It has to be practical. It has to be something the patient's going to be able to do. These inductions, ideally, you're going to see them every day in clinic, or at least speak to them on the phone, or be available to speak to them on the phone. And then again, harm reduction, all these patients, naloxone. I already said fentanyl test strips aren't useful for opioids, but it is useful for everything else, right? So there's fentanyl and cocaine, there's fentanyl and meth. The patients are buying things they think are Xanax, but it's actually pressed fentanyl. So we recommend fentanyl test strips for non-opioid substances. Teach any injection drug user, teach them about cleaning their skin, about using good water source, right? Distilled water, ideally, bottled water if they can, tap water. We've seen serratia infections from tap water. So, giving them the information, and then obviously using a sterile needle every time. At least give them the information. It's not always doable for these patients. And so when you do implement this, you want to have an action plan for these patients in case they do suffer precipitated withdrawal. What are they going to do? Do they have scripts for clonidine and Atarax and Zofran for at home? Utilize your motivational interviewing to help get these patients on board with the plan. Be flexible, right? These protocols, give the patients a choice on how they want to do it and change it on the fly if you need to. It's not a big deal. You don't have to stick to these protocols. They're not rigid. They're not evidence-based. They're just what people have done and worked. And if it does fail, revisit the patient's goals. Why are they ambivalent? And then do they need inpatient treatment? Are they unable to do this as an outpatient? And in order to save their life, they have to go inpatient, right? I mean, again, we've struggled in the hospital doing this for patients. You got to base it on your formulary insurance coverage, right? If you're doing outpatient, you cannot use these non-sublingual subcutaneous buprenorphine products, right? They can only be prescribed for pain. For OUD, you can only use Subutex, Suboxone, Sublocade, right? Those are your only choices. Some pharmacies won't let you cut films. We haven't really run into this. It's a very common practice. We do it in our hospital. We do it. We tell our patients to do it. But again, there's no data behind it. And so just some pearls from this talk. Fentanyl is not detected in opiate drug screens. It's very lipophilic, and that's why we end up with this prolonged clearance and prolonged period of precipitated withdrawal. Using standard buprenorphine initiation protocols don't work anymore if they're using fentanyl. If they do suffer precipitated withdrawal, more buprenorphine, and again, 32 milligrams that first day is what we recommend. And even for a few days after that, insurance companies may not cover it, which is an issue, but as an inpatient, we do that all the time. Again, microdosing protocols are designed to avoid precipitated withdrawal due to the minimal displacement of full opioid agonist. And then macrodosing is designed to provide enough agonism, which again, I can't wholeheartedly recommend, but some people are definitely doing it. And so we've had a few questions that were entered prior to the talk. So several patients have reported waves of withdrawal. And again, my suspicion is, again, the fentanyl levels are dropping slowly, and then you're going to have buprenorphine levels that are kind of going up and down as they're dosing. And I suspect that's what's causing the waves of withdrawal. What we are typically seeing in our patients, again, because we're doing like 32 milligrams or 24 milligrams, is they just don't feel right. It takes them, back when it was heroin and you would just have them staying overnight, start the next day, they would feel normal that day. You have to tell these patients, if you're using fentanyl, you may not feel normal for 2, 3, 4 days. Again, detailed strategy for precipitated withdrawal. You have to have your armamentarium of comfort medicines, and we recommend the buprenorphine hammer if they do suffer from it, if you can convince the patient to do it. UDS or oral fluids, again, it has to be specific for fentanyl. It cannot be for opiates, because fentanyl will not be detected on an opiate screen. If you're doing a GCMS or a time of flight, it should pick it up. But immunoassays for opiates will not. Induction difference between heroin and fentanyl is the timing, right? So heroin, again, it's one of those short acting, so you can wait 8, 12 hours and safely initiate them, as opposed to fentanyl, where we have seen patients have precipitated withdrawal 72 hours after their last use of fentanyl. What does fentanyl addiction look like? Fentanyl is just another opioid, so it looks like any opioid use disorder. Are there any other questions?
So you have a question that says, can you speak more on what you said about the treatment for precipitated withdrawal being more buprenorphine? How are you explaining that to patients?
So that is a very tricky conversation to have with patients. So basically we tell them that precipitated withdrawal from Suboxone is because we knock the fentanyl off the receptors, and that the only way to treat that is more buprenorphine. We need to get enough activity at that receptor to suppress the withdrawal symptoms. And again, you want to give the message in such a way that the patient's going to understand it. So speaking medical at that point is not helpful, right? Oftentimes we have our social worker, Emily, give that talk to the patients, because she is very, very good at communicating at the patient's level that they can understand, so that she uses metaphors and ways of describing it so that the patients understand that the withdrawal will improve with more buprenorphine. And that's kind of the key point, is if you cause withdrawal, giving more will make you feel better. And it's a very counterintuitive idea, but that you have to plant that seed in their mind. And that's how we do it. And again, Emily's amazing at talking to patients and can always talk them through that.
So I added in the chat, we also make sure to tell the patients that ahead of time, because they're more likely to be receptive to it if they know going in that that's what we're going to do than if we tell them when they're already feeling those symptoms. And then you have a hand raised for a question.
This is Allison. Thank you so much, Nate, for this talk. Really thoughtfully done, really balanced, and really just practical. So thank you so much for doing this, and we're really lucky to have you. I have a feeling that there's a lot of us who have a lot of questions. One thing off the top of my head is like, would your approach be different if the patient is using any other combination of substances? For example, the patient comes in, is using both fentanyl and meth on a daily basis versus alcohol versus sedatives, et cetera. I'm going to get that question out there, but the broader thing, because we're basically done with time, is I'm hoping that you might be willing to do something like this again, but actually do like just an open case discussion format. So for folks who have like specific cases, or for all of us sharing different experience and stuff, because all of this is pretty tough and it's really dependent on the resources and the setting that you're into.
Yeah. Yeah, I'd be more than glad to come back anytime, Allison.
Does your practices differ if the patient is also using other substances, specifically, let's say if they're co-using stimulants?
Typically not. So the one issue we have is the more substances they're using, the worse the withdrawal is. So we actually get, I guess we get way more aggressive with the quantity. So these patients feel terrible from all their withdrawal. So if you treat just the opioid, they're still going to feel terrible. And I guess we're much more aggressive with the symptomatic management. The opioid withdrawal part doesn't change, but the rest does.
Thanks. And I should actually say, we're lucky to have you and the entire ACT team. Really emphasize just how important all the other folks on your team is, especially in working with complex patients, that it's not just the pharmacology that's important, it's really talking patients through this.
Yeah, I'm just one part of the team. Every member of our team is just as important as me.
So you have another question in the chat, Nate. Someone says, we have a patient who snorts heroin or fentanyl. So whenever we restart her, we're microdosing. She has found that if she flushes her nose with a neti pot, she has an easier time. Is anyone else doing that?
That's interesting. I've not heard that before. I mean, it's hard to imagine that would be a physiological effect. You're not going to wash fentanyl out of the tissues. I guess if it's sitting in your sinuses, but yeah, if it helps her, it's worth doing. Just make sure she's using distilled water.
You've got another question. How do you skirt the legality of the Harrison Narcotic Act by giving a full agonist to bridge?
So I'm inpatient, so the Harrison Act doesn't apply to me. So you can't do that as an outpatient. Which is why the microdosing is so crucial. And the cross tapering as an outpatient is they're reducing their fentanyl use, right? You're not adding oxycodone, but they're reducing the amount of fentanyl they're using every day.
Question, just more clonidine if it's a fentanyl xylazine mix? Question. Correct.
Yeah. So xylazine is a central alpha agonist. So the treatment for that withdrawal is more central alpha 2 agonist. So clonidine, Xanaflex is a central alpha 2 muscle relaxant. That's another one you can consider using.
I think we have a hand raised. Go ahead and unmute.
Hey, Nate, this is Chris Frank. My question is, so based on this, do you think the standard of care is going to change in that these many of these starts are going to need to be done on the inpatient side rather than stumbled through on the outpatient side?
I think it's going to be, you try it as an outpatient microdosing, and if that fails, you do inpatient. Because again, a lot of these patients, they just can't stop their lives. Like if they have a job, going inpatient is, they have kids, like how are they going to go inpatient? Like they got no one to take care of their kids. They're going to lose their job. Like telling these patients they have to go inpatient is not oftentimes a reasonable goal. And, we offer to our patients, but life gets in the way.
Yeah, just as a follow-up to that, if you're in an area where you don't have options for inpatient treatment, are there any specific advice you give? Obviously, it sounds like just doing all the outpatient stuff that you have mentioned, but just any thoughts, and you're in an area where you don't really have that as like a close by safety net.
Yeah, I mean, again, this is part of the struggle of the fentanyl, is just, what are you going to do for these patients when they can't do these microinductions? I honestly don't know what the answer is, because there's no good answer. So some people say you can just do Sublocade, right? You're not going to precipitate withdrawal because of the depot formulation of the Sublocade. So that would be one thing you could consider doing. If everything else has failed, give them Sublocade. Like, people are using the weekly buprenorphine. I don't think it's approved by the FDA, but they have access to it through research studies. And they're saying they're not seeing any precipitated withdrawal when they do that. And that would be perfect, right? You give them a week, you give them an injection, and then a week later you start the sublingual, right? But that is something I would consider if you have access to that. But that, if you do precipitate, those patients are totally hosed.
Your next question, any success with patients self-bridging with kratom to wash out fentanyl?
So, I mean, we have treated kratom multiple times, the patients that can't get off the kratom, but in theory, that's not a terrible idea, right? So kratom, the issue with kratom is, you don't know what you're getting. It's not managed by the FDA, so you don't know what's in that product they're using. You don't know the doses, but in theory, and again, I'm not sure I would recommend that to patients, because you're going way off the reservation on that one. It's the same as using oxycodone, right? You're using a different opioid to let them wash out the fentanyl. So in theory, and then you can start the sublingual 12 or 24 hours after that last dose of kratom, because we have not had any problems converting patients on kratom. So in theory, that is not a terrible idea. I would have trouble recommending it, but it probably would work. The dose of kratom you'd have to use is going to be crazy high. Yeah, so if I had access to IV buprenorphine, I would definitely use that. There's no question about that IV buprenorphine would work fine. Again, I don't have any experience with it because we don't have access to it, but lots of people use it without any problems. And it's easy to dose. So you do something like 0.15 milligrams every 6 hours and then up titrate from there.
It seems like there's multiple different protocols, as you have showed. Do you think that it's that the reason we have all these multiple protocols is this is kind of a relatively new thing that we're wrestling with, and that we haven't kind of settled on like a specific best practice? Or do you think it depends so much on the patient and the specific circumstances that this is why we have, kind of all these different ways to approach this and multiple ways to skin a cat?
I think it's both, right? We're operating with very little evidence. So everyone is doing what they think works. And every patient they see has different situation. So you're going to get, I mean, personally, half the time I do it different on each patient. Like I don't do it the same way for every single patient. And so you have, exponential increase in complexity when you're talking about multiple protocols, and then every patient is an individual with individual needs. So it's both. There's no evidence-based medicine, so everyone's coming up with their own protocol, and then each patient has different circumstances. So you're not going to get, it's going to be hard to imagine anyone coming up with a big study using one protocol. It's possible, but I'd be excited if they did, but that never happens.
The Michigan Opioid Collaborative just wants to thank Dr. Menke so much for your time today. We will definitely be following up for kind of a part 2 for this. And we would love to have Dr. Menke and the ACT team back with us to continue this discussion, as almost 60 of us have stayed over to listen to the question and answer portion today. And so we're grateful for everyone's time. We want to thank you again for joining us. Please continue to check out the Michigan Opioid Collaborative website for more events on our website page. We would love for you to register and join us. A few of us will be hanging out for just a moment more if you do have some last minute questions. But otherwise, we would like to thank you so much and enjoy the rest of your day.